6, yes, 6 it is. Right. Hello. Good afternoon, ladies and gentlemen. We have now the case presentation. First session is, there are 6 papers. The first presentation is by Ulhas Pandurangi from Madras Medical Mission, Catheter Ablation of right atrial appendage to right ventricle connection. Dr. Ulhas Pandurangi.
Good morning. Good morning to one and all. I am Jaya Pradhap from Madras Medical Mission, Chennai. It's my privilege to present a case of right atrial appendage to right ventricular connection in IHRS 2019. At the outset, I would like to thank Dr. Ulhas and Pandurangi for giving me this wonderful opportunity. This was a case of 19-year-old male with on and off palpitation for 12 years. RFA was attempted elsewhere at the age of 10, which is suspected anteroseptal accessory pathway, and his echo was normal. And this was his baseline ECG, shows pre-excitation. As you could see here, R in V1 is unusual for an anteroseptal accessory pathway, which could be the reason for previous failed ablation. So we thought this is an unusual accessory pathway. The patient has a regular narrow QRS tachycardia, which is orthodromic AV-RT, and the baseline interval shows short HV. During atrial pacing, maximal pre-excitation morphology was noted, which is suggestive of right free wall accessory pathway. And this pathway was robustly conducting, whose refractory period is less than 240 milliseconds. Then we went on mapping tricuspid annulus, which does not show any satisfactory early signals. So, using 3D electroanatomical mapping, during tachycardia, earliest A was mapped, and this was at the region of right atrial appendage. Then ablation catheter RF12 at the right atrial appendage shows closest VA during tachycardia, and during sinus rhythm closest AV. As you could also notice the pathway potential. So we thought this is the place where we need to ablate. Before ablation, we did a right atrial appendage angiogram, and we want to be sure during ablation we are not going to injure a right coronary artery. So we did a right coronary artery angiogram. As you could see in RAA view and LAA view, the tip of the ablation catheter is away from the right coronary artery, so we are quite safe. We then proceed with the ablation using flexibility irrigation catheter, because conventional catheter may cause increase in impedance. Within few seconds, pre-excitation got disappeared, and there were no pre-excitation on post-RFA ECG and no recurrence on follow-up. The relationship between right atrial appendage and the RVR, the tip of the right atrial appendage is anterior and superior, overlaying anterosuperior aspect of the AV groove, a band-like muscular structure extending from the underside of the right atrial appendage to the right ventricle act as an accessory pathway. As you could see here, the right atrial relationship between the right atrial appendage and the right ventricular outflow tract, they are quite close, and the right coronary artery is behind the right atrial appendage. The difficulties are the trabeculation at the right atrial appendage may prevent adequate contact between the ablation catheter and the tissue. Multiple energies are required in case of epicardial pathway. Exact localization of the accessory pathway by 12-lead ECG criteria is difficult in the absence of true right AV valve annulus. The right atrial appendage valve is thin, so we have to be careful during ablation whether we are perforating it or not. Of course, 3D electroanatomical mapping plays an essential role here. The features suggestive of this variant pathway are a pre-excitation pattern indicative of right anterior or right anterolateral accessory pathway, retrograde atrial activation recorded earlier in the right atrial appendage then at the tricuspid annulus, failed or transient loss of pathway conduction with RF delivery at the tricuspid annulus, need for high energy delivery within the appendage to achieve permanent pathway elimination. Thus, I would like to conclude here. Thank you.
So maybe I have a quick question for Jaya Pradhap. Very nice presentation. Can you go back to that anatomy picture that you had? So if we can have the slides again. Yeah. So here your point is the tip of the appendage is overlying the ventricle. Part of the ventricle that it's overlying is the outflow tract. So usually outflow tract ventricular activation, AVR and AVL both are negative. And second, the tip of the appendage is beyond the right coronary artery. So if you go back to your angiogram, yes. So yes, if you just show that, if we look in the RAO view, the artery here is more ventricular than where the catheter is located. And if you go back to your ECG, we're seeing here AVR is negative, but AVL is positive, something we don't see in the outflow tract. So how do you reconcile that? By anatomically you felt this was close to tip of the appendage going, but yet it's more atrial than the coronary and AVL is positive. Thought process there? Maybe do you feel this could be an unusual appendage location, like it's more lateral than usual in this patient compared to that anatomy picture? And just like we see CS diverticula, sometimes this lateral wall of atrial appendage region also has these outpouchings, and maybe that was causing the accessory pathway. Yes, Ulhas. Yes, please.
This should be looking like an RVOTVT when we maximally pre-excite. The angiogram did not show a good distortion or abnormal feature of right atrial appendage, what you just now described. When the patient was subjected to the TE, our echocardiographer could tell that he was blinded to this whole affair. But he typically made a comment, the right atrial appendage is abnormally enlarged, circular.
Okay.
So that probably explains that.
But I really want to congratulate just such nice understanding of the case. Really reflection, I've seen second time now, reflection of the coaching and interest in your lab. Very nice to see.
Ullas, did you look for a unipolar signal in this case?
He did not show. Yeah, we have looked at it. That looked good.